Good afternoon. It's my privilege to be in front of you people. We saw the SKS done today, and this is pretty much similar to what you saw live today, except for the fact that I have part 2 of this too. I have no disclosures. So this was a left main bifurcation done as SKS. This was a 68-year-old. 6 years back, surgery was done, ejection fraction was low, had persistent angina. Lima to LAD was functional, and we have a left main bifurcation lesion. As you see, the LAD is running into a good-sized diagonal branches, 2 of them. And as I mentioned earlier, the Lima to LAD was functional. So this was done as SKS technique. First, we wired the LAD into diagonal and do a rota. Then we do a balloon to the left main circumflex, and then we put 2 stents into left main LAD and left main circumflex, just as you saw this afternoon. An SKS done with high pressure inflation, and this is the SKS 2 stent deployed. And this is the final result. This was done with debulking followed by stenting. The story doesn't end here. The patient had severe limiting angina about 4 months after this procedure. Lima again to LAD is functional, and the distal LAD looks a reasonable vessel, and you can see the instant restenosis of the SKS stent, more into the diagonal and slightly less extent in the circumflex region. So how to address is generally an important issue, because many of you who have done SKS know that if we have to even post-dilate with another non-compliant balloon, the entry of the balloon sometimes is quite a job. So we started with surgical opinion, and the LAD on CT angio was stuck to the sternum. So this increased the surgical risk to a very high extent. In fact, our surgeon was talking of 25% risk, so we got him to cath lab. So this is a CrossFit 100 wire into the LAD going into left main. However, at this stage we started balloon dilatation, and none of the balloons could enter into the segment. We don't know which lumen we picked up when we got our wire in. So maybe we started from stent towards circumflex and then got into LAD, maybe. However, the balloon entry with whatever we did, including support with guideliner, etc., was not possible. So we at this stage switched our focus to circumflex, wired the circumflex with a run-through wire. This was dilated with 2.5 and 3.0 NC balloon. And then we decided to stent left main to circumflex, assuming that we'll address the LAD after this particular stenting.
This is like converting it to a colloder technique. This is a conversion, really, right?
Yes. This was stented, and since there were too much of metal layer at that stage, we lost the flow to...
minor problem.
Not a minor problem. We had to put a balloon pump. Patient went on to ventilator at this stage. So certainly not a minor problem. We presumed that the LAD is protected and we wouldn't run into this kind of problem. But at this stage, as we lost flow, we had to... So as I've shown in the diagram, there were too many metal layers. However, we were able to recross into the LAD. And now, of course, the patient went on to a balloon pump. D1, however, now could be crossed with a balloon. So something which was not possible earlier, maybe we disrupted the layers of the stent and we were able to cross, as you can see here. So we did some dilatation there. I guess we have completely crushed the left main LED stent, which was placed earlier, and we are completely by the side of these stents. So we now come in with a slightly bigger balloon, exchanged it over an OTW balloon to a run-through wire, hoping that this would give us better support. The stent, I mean, this was a standard trapping technique that we used to exchange. The balloon 2.5 and 3 were used to dilate and make space for the stent. However, as you can see, the stent could pass only to difficulty, only to an extent. So the stent at this stage was not able to go beyond this point. So we bring in another wire, the buddy wire, and over the buddy wire we were able to get the stent in. So the first wire did not allow the stent to go in, but the buddy wire allowed the stent to go in. So probably there was something like a realignment issue at this stage which allowed. So beyond the stent, now we see some kind of dissection or a long narrowing. We did not want to leave it unaddressed because if it closes, it would be too difficult to come in. And that portion was dilated. This buddy wire was introduced. At this stage, again, the second stent would not go in. But it finally went in again on the second wire. So buddy wire sometimes comes really handy, not just to give some kind of support. So this is how we finally end up with this kind of stent placement. I presume the LED stent old stent was completely smashed on one side. And we have worked through 2 layers of the stent. First one, which was going from left main to circumflex, then the second one is deployed, and through that we've been able to go through. So SKS, though it's very easy to apply, I think in acute angle bifurcation, SKS is very easy to achieve. I think it works very well only in specialty hands and not for an average person. Thank you indeed for your attention.
So, I mean, this idea of SKS, which I used to do all the time 10 years ago, but because of this very problem, I kind of gave it up. It's easy to do the SKS, but then you have restenosis. It's a big issue. So why do SKS besides the fact that it's easy to do? Why not start with something like we saw today, the DK crush, or maybe culotte for left main? What's the reason for the SKS?
Well, incidentally, Dr. Samin did it during one of the live cases from my hospital. The first procedure was done as SKS by Samin. And you can't stop Samin saying that don't do it, you know. So this was a live demonstration.
I'm keeping him busy right now with the LAD in the cath lab.
Thank you.
Thank you very much.